I'm Takeshi Tohyama from Kyushu University Hospital. In this presentation, I will show you machine learning model to predict one-year mortality of heart failure patients from DPC data. I have no financial conflicts of interest about this presentation. First, risk stratification for heart failure patients provides fundamental strategies of clinical decision-making. As shown on the right, several risk models have been developed to stratify heart failure patients. Recently, many researchers have applied machine learning to predict mortality. This panel shows machine learning approaches achieved high accuracy to predict mortality. Like this study, if we incorporate more predictors into the model, we could get a better prediction. However, given the user of the prediction model are not only medical staff but also patients and non-medical staff, the ideal prediction model should be accurate but simple and user-friendly. In our recent studies, we built up a heart failure registry named JCS. Since this registry followed up hospitalized patients for up to 5 years, this is a valuable database for developing predictive models. In addition, JCS includes DPC data as well as clinical information. DPC data is available in the JCS. Although DPC does not contain detailed clinical data such as laboratory and physiological data, DPC provides valuable data for the predictive models. The advantage of DPC is being structured, not free text. This makes it very suitable for analyzing large-scale data. Based on this background, we aim to predict the one-year mortality from DPC and develop an easy-to-use prediction model. The input variables of the machine learning models were derived from the DPC, and the output is one-year mortality. At first, we developed machine learning models and examined important variables. After that, the developed models were compared with the conventional models. From JCS, about 10,000 patients were included in this study. Of these, 80% of data were used for model training, and 20% of data were used for model comparison. We extracted 89 variables from the DPC. These variables are basic information during hospital stay, comorbidities, medical procedures, and prescriptions. To develop machine learning models, we compared 6 orthodox machine learning algorithms. Among machine learning algorithms, the voting classifier achieves the highest C statistics. Using the voting classifier, we evaluated the important predictors. As you can see, the Basel index representing ADL was the most powerful predictor for one-year mortality, and age, body mass index, duration of hospitalization were very powerful predictors. From this analysis, we extracted 8 powerful and easily available predictors and developed a simplified AI model as SmartHF. This is the main result of this study. The ACDVC is a machine learning model with all 89 variables from the DPC, and the SmartHF is a simplified model using the important 8 variables. The figure and table show that ACDVC and SmartHF achieved better C statistics compared to the conventional risk models. The SmartHF developed in this study can be used by anyone, so we created a web app available via the internet. You can use it with the QR code on the bottom. In conclusion, the machine learning model based on DPC data shows good prediction in one-year mortality. In addition, the SmartHF with a simplified model provides easily operable risk stratification. Finally, our approach reveals the Basel index is the most important prognostic factor. Thank you for your attention.
Today I go over my presentation in the JCS 2022 regarding the CLIDAS real-world database. The CLIDAS acquires electronic clinical data directly from hospital information system that are stored in the SSMIX2 storage. The data from PCI, electrocardiogram, and echocardiogram are formatted into CMAT standard export data format. The CLIDAS accumulates such multimodal data and clinical outcomes, which was anonymized and accumulated to the central server. The CLIDAS has been developed continuously, and today we present the first fixed result from the 9690 patient after PCI, including 4100 ACS patient and 5500 patients with chronic coronary syndrome. We assessed the incidence of major cerebral and cardiac adverse events in the primary analysis and exploratory assessed 3 clinical questions. There were significant differences in baseline characteristics between ACS and chronic coronary syndrome. As you can see, the incidence of diabetes, atrial fibrillation, CKD, previous MI, PCI, CBG, stroke, heart failure, hospitalization, PAD, and malignancy was all higher in patients with chronic coronary syndrome. Data from SSMIX2 showed that the baseline lipid profile was worse in patients with ACS, and BNP was also higher in the ACS patient. The baseline prescription of lipid-lowering agents were less frequent in patients with ACS. In contrast to the baseline, prescription data within the day 0 to 30 indicates that the use of high-dose statins is increasing by the year of index PCI, especially in patients with ACS. This is the primary result. The incidences of MACE was 7.1% per 2 years in patients after ACS who underwent PCI, and 3.9% per 2 years in patients with chronic coronary syndrome, and these were significantly different. The incidence of cardiovascular death increases in the acute phase of ACS, as you can see in the left panel. By contrast, in the 19-day landmark analysis in the right, the cardiovascular death is not significantly different between patients with ACS and CCS, and even higher in patients with chronic coronary syndrome. In contrast to cardiovascular death, the risk of myocardial infarction after index PCI was consistently higher in patients with ACS. The unadjusted hazard ratio was 2.2, and the risks of stroke were not different between patients with ACS and CCS. In the first clinical question, we assessed the associations between statin dose intensity and the occurrence of myocardial infarction based on the detailed prescription data in the CLIDAS. As you can see in the left panel, the risks of MI was lowest among patients who were prescribed with high-dose statins in the first 30 days. There were significant differences of hazard ratios between high-dose statin and moderate dose, and also high dose and low or no statins, after the adjustment for the propensity score for statin dose intensity. By contrast, in chronic coronary syndrome, differences between high dose and moderate dose statins was not significant. These findings support the current JCS guidelines for ACS that emphasizes that the use of maximal dose of statins in patients with acute coronary syndrome. In conclusion, we could establish the CLIDAS that acquires multimodal clinical data directly from hospital information systems. Thank you very much.